Okay, so we're going to talk about neurology from Crush Step 3. You have two different types of things, delirium and dementia. Delirium are and dementia both are going to be associated with hallucinations, illusions, delusions, and orientation difficulties. And orientation is person, place, and time. They could also be associated with sundowning, which means that the symptoms might be worse at night. Now, you got to remember that memory is going to be associated with delirium, and dementia, you're going to have your memory spared. So if you want to be concerned about memory, memory is spared in dementia, M-E-N-M-E for memory. So watch out for that. We'll also watch out for pseudo dementia, means it could be something that could be found in the elderly, but it's a manifestation of depression that's usually reversible with treatment. So the treatable causes of dementia, again, remember memory is spared, include vitamin B12 deficiency, endocrine disorders, endocrine meaning like the thyroid or the parathyroid. It could be due to uremia, like if they had kidney failure. It could be due to syphilis, brain tumors, or some type of normal pressure hydrocephalus. So think about memory type things, think about the head, and think about what could be going on. Treatment of Parkinson's syndrome may also improve dementia. Again, dementia memory is spared. You also want to watch out for thiamine deficiency. Now, thiamine deficiency is commonly seen in alcoholics, and it is a cause of delirium. Delirium, remember, you are going to have some effect on your memory. So, thiamine deficiency in alcoholics is a cause of delirium, which is also known as Wernicke's encephalopathy. Now, the classic presentation of Wernicke's encephalopathy is going to be ataxia, ophthalmoplegia, nystagmus, and confusion. And the way I would like to remember this is COAN, C-O-A-N. C for confusion, O for ophthalmoplegia, A for ataxia, and N for nystagmus. So, if untreated, the delirium, which is affecting with memory, may progress to this thing called Korsakoff syndrome. And Korsakoff syndrome usually involves anterograde amnesia, meaning they can't remember things that will happen. So, inability to form new memories. And we said delirium is also affecting the memory. It can also lead to confabulation, which is usually irreversible, and confabulation is they basically make up all these stories. So remember that thiamine deficiency can lead to delirium in alcoholics. So what is the treatment? Give thiamine before you give glucose, because thiamine acts as a precursor in order to prevent the precipitating Wernicke's encephalopathy. Now, the next segment is called headaches. There are different types of headaches and causes. One is a tension headache. Cluster headache is the next one. Migraine headaches. It could also be due to a tumor or a mass in your head or pseudotumor cerebri. It can be due to meningitis. It could be due to subarachnoid hemorrhage, or it could be due to some type of outside cause, some type of extracranial cause. Now, a tension headache, which is the first one, is the most common type of headache. You have to look for a long history of headaches. You look for stress. You look for them feeling tightness or stiffness in their head. And usually it's in the front, or it's right above their eyes, or it's on both sides. So you want to look for tension headache. Now, you treat the stress one by reducing your stress. And you can use acetaminophen, which is Tylenol, or you can use NSAIDs. Now, the next one is called a cluster headache. Cluster headaches are unilateral, one-sided. So they're not bilateral like in tension headaches. They're not usually right up in the frontal area, or right above your eyes. So cluster headaches are in one area. It's a cluster. It's severe though, and it's tender, and it occurs in clusters. It comes and goes. But you might want to use some oxygen, because that could kind of get rid of an acute attack. Migraine headaches, you want to look for aura, you want to look for photophobia, you want to look and see whether or not they have nausea and vomiting. So, and positive family history. Patients may occasionally have neurologic symptoms during an attack. Migraines usually begin between ages 10 and 30 years of age. You want to treat or prevent with an anti-migraine medication like sumatriptan, okay? So migraine headaches, you want to look for aura, you want to look for light, too much light, you want to look for them to be nauseous or vomiting, family history. They may occasionally have neurologic symptoms during the attack. Migraines can usually occur between the ages of 10 and 30. And what you want to do is treat or prevent with an anti-migraine medication like sumatriptan. The other reason that you could get headaches is either through a tumor or a mass. You look for progressive neurologic symptoms. So the the symptoms keep getting worse, but then you see all of this papilledema, which is a lot of fluid behind the eyes. You look for intracranial hypertension. Classically, when you have too much pressure in your head, you might have nausea and vomiting, and this nausea and vomiting could be projectile. So you want to look for mental status changes. Remember, we're looking for progressive neurologic symptoms. You want to look for headaches every day that are classically worse in the morning. So tumor or masses are going to be classically worse in the morning. You'll see papilledema. You want to look for a CT or an MRI, and you want to get contrast. And that's what you should order to see whether or not there is a tumor or a mass. The next one is pseudotumor cerebri. It may mimic a tumor or a mass because it also causes intracranial hypertension. It also causes papilledema, and it can lead to daily headaches that are classically worse in the morning, so everything like a tumor or a mass, but they also may be accompanied by nausea and vomiting, and they're typically found in the young obese woman. You want to get the CT and MRI with contrast because already you're starting to think that maybe this is a tumor or a mass. But unfortunately, those scans are negative. So it's not the tumor or a mass. And you do a lumbar puncture, and what you're going to find is an elevated opening pressure with no abnormalities found with the lumbar puncture. So then you start thinking pseudotumor cerebri. Patients have a permanent visual loss without treatment, so you really want to make sure that you treat these young, obese women, and you treat them with supportive measures. You tell them to lose some weight, and if not, repeat the lumbar punctures, or you may need a shunt because there's all this intracranial hypertension. Large doses of vitamin A, tetracycline, or heavy withdrawal from corticosteroids are possible causes for having pseudotumor cerebri. The next thing is meningitis. You want to look for fever, Brudinsky sign, and Koenig's sign. Brudinsky's is bringing the head down to the chest, and then Koenig's is lifting that leg up towards your heart. CSF findings are going to be part of the table. The next thing that it could be is a subarachnoid hemorrhage, also known as SAH, and it is often described as the worst headache of my life. They may be due to a congenital berry aneurysm rupture, or it could be due to trauma. You look for gross bloody CSF through the diagnosis, though the diagnosis should be made with a non-contrast CT, not lumbar puncture. You want to treat them supportively and try to diagnose an aneurysm if no history of trauma is present. And therefore, you would order a cerebral angiogram. And finally, extracranial causes can be eye pain, like optic neuritis, eye strain from refractive errors, iritis, or glaucoma. It could be due to middle ear pain, which is otitis media or mastoiditis. It could be due to your sinuses from sinusitis. It could be due from an oral cavity pain, like a toothache, or herpes zoster's infections with a cranial nerve involvement. Or it could finally be non-specific causes like malaise from any illness. Okay, so that takes care of this neurology and headaches.